Hello doctors. Today we are here with another topic of pediatric surgery, that is biliary atresia. First we will understand what is biliary atresia. Biliary means gallbladder, bile ducts, which includes common bile duct, common hepatic duct, and right and left hepatic duct, cystic duct, and gallbladder. The biliary tree and the gallbladder is known as biliary. And atresia means either there is obstruction or there is agenesis which causes atresia. So you know, if there is a biliary tree including gallbladder which have an obstruction or agenesis, this is known as biliary atresia. The biliary atresia is the disease affecting the both intra and the extrahepatic biliary tree is known as biliary atresia. Obstruction of the bile duct, cirrhosis, and liver failure occurs because of the biliary atresia. There might be a physiological jaundice present in the neonate, but it gets resolved within 1 to 2 weeks. If there is an persistent pathological jaundice beyond 2 weeks of life, then we have to suspect the biliary atresia. So the history, first we will know something about the history. This was described by John Thomson in 1892, and Ladd was the first who reported successful surgical correction of the biliary atresia in 1928. This was the Ladd. And the most recent form of surgical treatment for biliary atresia is Roux-en-Y portoenterotomy. This is also known as Kasai procedure. So this is also known as Kasai procedure. Most common diagnosis leading to liver transplant in children is biliary atresia. The most common cause of liver transplantation in children is biliary atresia. Now the incidence. Incidence is approximately 1 in 10,000 birth, and it is more common in females, slightly more common in females, and it is higher in Asia than the other parts of the world. So first we will know the classification of the biliary atresia. The classification is given by the Japanese Association of Pediatric Surgeons, proposed classification based on the location of the atresia. So there are three types: type 1, type 2 and type 3. Type 1, as you can see, this is, first I will tell you the part. This is the right and left hepatic duct, then this is the common hepatic duct, then we have the gallbladder, cystic duct, and which forms the common bile duct, and then it goes into the ampulla of Vater and opens into the second part of the duodenum. So in the first type there is, we will in this classification we will start from the downside to upward. Like first there is atresia of the common bile duct. In the second type 2 there is atresia of the common hepatic duct. And in the type 3, there is atresia of the bile duct and porta, like where the left and right hepatic ducts are dividing. This is known as the porta junction. And this is type 3, and this is most common type. So most common type of biliary atresia is type 3 of Japanese Association of Pediatric Surgeon classification. Remember this, and this is most common where the biliary atresia occurs. Now etiology. Etiology is still very unknown because there are so many multifactorial factors because of which biliary atresia occurs. So the factors may be common are like it can be unknown, or it is multifactorial. There may be a genetic factor, inflammatory factor, or infectious factor like infection to the reovirus or rotavirus or cytomegalovirus. If this infection might cause biliary atresia, and epidemiology is more common in the winter months. In the winter month, the patient have more chances of biliary atresia, might be because of the infection of these infections are more common during the winter season. And 20% are associated with congenital malformation. So 20% of the patient with biliary atresia might have congenital malformations. The other causes of biliary atresia are bile duct ischemia, abnormal bile duct metabolism, or there may be a pancreaticobiliary maljunction or environmental toxins which might cause biliary atresia. And these abnormal condition, there will be secretion of some cellular cytokines in the body. So cellular cytokines involved in biliary atresia are CD4, CD56, ICAM1, VCAM1, interleukin 2, tissue necrosis factor alpha, and reovirus type 3. These are the cellular cytokines which are involved in the biliary atresia. Now, etiological heterogeneity. You have to know this, very important. There is mainly either we can see isolated BA means biliary atresia. Either we have isolated biliary atresia, which is more common. 80% of them are isolated, or it may be associated with splenic malformation, that is biliary atresia splenic malformation syndrome. This is known as BASM. I will repeat, that is biliary atresia splenic malformation syndrome, which is 20%. But more common is isolated biliary atresia. And this biliary atresia might have cystic dilutation, or it is associated with cytomegalovirus or chromosomal abnormality. This might be asked in MCQ question. What are the chromosomal abnormality? One is the chromosomal 22 aneuploidy, another one is cat eye syndrome. This is asked in MCQ. So this is important. Chromosomal abnormality. Now remember, I have told you two main variant, that is isolated biliary atresia or biliary atresia splenic malformation syndrome. So here I have made a chart so that it will be easy for you to understand. First, we have the early first trimester and the late first trimester. In early first trimester and late first trimester, there is a bile duct development occurs. If in early first trimester there is any kind of abnormality, that is because of the maternal factors, like if the mother have diabetes, or possible specific genetic factors, if these two are present and there is an abnormality during development of the bile duct, then it causes BASM. What is BASM? BASM is biliary atresia splenic malformation syndrome. Fine. If there is in the late first trimester, if there is any problem like perinatal hepatotoxic virus, if the mother get infected via the reovirus, rotavirus, there will be possible immune dysregulation or upregulation of the pro-inflammatory genes, or there will be possible genetic susceptibility. So this, if there is abnormality during late first trimester, then we have the isolated biliary atresia. And I have already told you, isolated biliary atresia is present in 80% of cases and BASM is present only in the 20% of cases. So this is the main pathology of the biliary atresia. Now we will see first the biliary atresia of splenic malformation, few of the points. This syndrome was first reported in 1993 and the splenic anomalies were inconsistent with the not alone spleen. Along with the spleen, there is abnormality in cardiac. There is cardiac abnormality. There might be situs inversus or pre-duodenal portal vein, or absence of vena cava may be present in these children with BASM. And embryonic insult in critical window period of 30 to 35 days of gestation. Like in early trimester, I have already told you. That is, in early trimester, if there is an embryonic insult, there will be formation of BASM. And this is also linked with the maternal diabetes, as told here. Either maternal diabetes or pre-genetic condition in early first trimester causes BASM. Now, spectrum of anomalies. What are the anomalies which is also related to the BASM, associated anomaly? Number one, already the name suggests, as for spleen. The spleen may be polysplenia may be present, or there double spleen that is seen in 95% of cases, or there is asplenia in 5% of cases. There may be situs inversus present in 50% of cases, or venous malformation like pre-duodenal portal vein, presence of pre-duodenal portal vein, which generally gets obliterated, but if it still persists, there will be pre-duodenal portal vein, or absent vena cava or interrupted vena cava may be present. Intestinal development anomaly is malrotation. There may be atrial septal defect, ventricular septal defect, or Fallott's tetralogy is present in 40% of cases. Liver might be normal, or there may be a mirror image. Biliary appearance is solid and scanty gallbladder can be seen. We can find a contracted or fibrosed gallbladder might be seen in cases of biliary atresia. There might be annular pancreas, and in miscellaneous there may be immotile cilia syndrome, which is also known as Carter-Jenner syndrome. This might be also present in biliary atresia. Now we will see pathophysiology overall. The hepatic diverticulum is in 1 month, in 4th week of gestation, there is formation of hepatic diverticulum from the foregut, and cranial and caudal component causes the extra and intrahepatic portal, extra and intrahepatic duct formation. Earlier it was thought that there might be error in recanalization of the bile ducts. Therefore, there is biliary atresia. This was the earlier theory. So, pathology is occlusive panductular cholangiopathy affecting both the intra and extra bile duct. And if we take a percutaneous liver biopsy, the bile ductular proliferation can be seen, and there will be bile stasis, periportal inflammation, and there will be presence of giant cell where in varying degrees of fibrosis may be present. And histology, there is patency or partial patency of the duct are present in cases of biliary atresia. Now, clinical features, there will be progressive jaundice, there will be alkaline stool, dark urine, and firm hepatomegaly. Why this occurs? Because as we have the liver, after that we have the right and the left hepatic duct, then we have common hepatic duct, then we have the common bile duct here. If there is biliary atresia, the conjugated bilirubin cannot pass. Therefore, there will be feeling of bile. If the biliary atresia is proximally present, there will be contracture of bile. If there is biliary atresia distal to the cystic duct, then there will be feeling of bile in the gallbladder also. So bile will be filled, and this bile will be pushed into the liver. And here we have the blood vessels. So the conjugated bilirubin will go into the blood vessels, and this bile will accumulate in the liver and will cause progressive jaundice and will also cause hepatomegaly. It will also cause hepatomegaly. And there will be clay colored stool as we see in conjugated bilirubin. Dark urine will be present. This conjugated bilirubin will go into the blood. This blood will go into the kidney, and when the urine also have the conjugated bilirubin, which causes the dark color, and there will be firm hepatomegaly, as I have told. In advanced disease, if not treated, then later on there will be palpable hepatomegaly. The liver will be so big. There will be splenomegaly because of portal hypertension will be present. Ascites will be present because of portal hypertension, and patient will have failure to thrive, and malnourishment will also be present. If not treated, it is very fatal condition after first 2 years of life. In first 2 years of life, if biliary atresia is not treated, it is a fatal condition, and survival is less than 10% in 3 years. Now we have seen the clinical feature, we have seen the pathology, causes. Now we will see the diagnosis. How will you diagnose this condition? Remember, the gold standard test is intraoperative cholangiogram. It is not liver biopsy. This mistake is done many times. So therefore, remember this. The gold standard test for biliary atresia is intraoperative cholangiogram. This is important, and remember this. Now, first, a neonate came to you with an conjugated jaundice and pale stool. After exclusion of medical causes like alpha-1 antitrypsin deficiency or torch infection, these are the differential diagnosis of the biliary atresia, we will do the ultrasound. In ultrasound, remember, this is asked many times in MCQ, in NEET, PG and SS also, that is abnormal cord sign. If abnormal or triangular cord sign this is also known as triangular cord sign. If there is abnormal cord sign present in ultrasound, 80% of cases of biliary atresia we see this sign, and this is a pathognomic of biliary atresia. So after doing ultrasound, there may be dilated intrahepatic ducts with or without cyst. Then we will do MRCP, ERCP, or we can do PTC. And then if we find any kind of obstruction, if obstruction is found, then emergency laparotomy is done. And if obstruction is not found, then we can electively treat the patient for elective laparotomy. No emergency laparotomy is needed. But if there is non-dilated intrahepatic duct, we need to exclude the biliary atresia, and we need to do the liver biopsy. If we do the liver biopsy and we have an equivocal large duct, then we can do ERCP, or we can do radioisotope scan via the HIDA scan, or DISIDA scan. What is DISIDA? DISIDA is diisopropyl immunodiacetic acid. This in how this is used. First, before this test, the neonate pre-treatment is done with phenobarbital. Phenobarbital is given at 5 mg per kg per day for 5 days. Why phenobarbital is given? Because phenobarbital increases the biliary excretion. Therefore, phenobarbital is given for 5 days. Then, after 5 days, we inject the patient with Dicida or Hida. And after Dicida, after 24 hours, remember this, after 24 hours, we see the bile excretion. That is bile present in duodenum or intestine. If the bile is present in duodenum or intestine, means there is normal biliary duct, there might be no biliary atresia or partial biliary atresia may be present. But if there is no bile present in the intestine or duodenum, then we know that the patient have the biliary atresia. So this is once asked in NEET SS exam. That is, after how much time we see the, after giving Hida, after giving the dye, after how much time we see the bile in the intestine. That is, after 24 hours we see bile in the intestine. So this is Dicida scan. This is the Hida scan. This is how it look like. It can be asked with a picture also. Now, what are the differential diagnoses? As I have already told, differential diagnosis, one is the TORCH infection. There may be genetic abnormality like antitrypsin, progressive familial intrahepatic cholestasis may be present, or metabolic disorders, or obstructed choledochal malformations, or spontaneous perforation of bile duct may also be present, which might mimic biliary atresia. Now, treatment is, first you need to stabilize the patient. Broad spectrum IV antibiotics are started. Fat soluble vitamin, because fat soluble vitamin are A, D, E and K. Vitamin A, D, E and K are given. As liver failure is present, fat soluble vitamin there will be a deficiency of fat soluble vitamin in the neonates. And intramuscular vitamin K is also given. And the surgery that we do today for biliary atresia is Roux-en-Y hepatico-potoenterostomy. I have said this in the starting of my video. This is also known as Kasai procedure. This is a Kasai procedure. As we can see, this is the liver. Fine. This is a liver. This is intestine, small intestine connected to the liver, shown in green color. This is the liver. We have the stomach, and then we have the pylorus, duodenum, and this anastomosis. From this anastomosis and this anastomosis, the Roux limb, this is known as Roux limb, and this Roux limb is connected approximately 40 centimeter from this potoenteric anastomosis. 40 centimeter distal to it, there is anastomosis of the Roux limb. And we, in this Kasai surgery, we give a rooftop incision in the abdomen. Why rooftop is given? Because not only liver, we also have to see the spleen. Because of BASM, the spleen might also be involved. There might be polysplenia or splenomegaly, or there might be asplenia, or portal hypertension might also be present. Therefore, rooftop incision is given to see the liver and to see the spleen also. Now, intraoperative cholangiogram, I have to say some few points about it. This is a picture of normal intraoperative cholangiogram. How this is done? And I have already told, intraoperative cholangiogram is the gold standard. So here we have the gallbladder. This is the normal intraoperative cholangiogram. This is a gallbladder, right and left hepatic duct, common hepatic duct, cystic duct, joins, cystic duct and common hepatic duct joins to form the common bile duct, then pancreatic duct joins, and there is a flush of the dye in the duodenum. In this case, how it is done, we secure a purse string suture on the gallbladder. This is the gallbladder, we secure a purse string suture. An angiocath or laparoscopic cholangiogram catheter, a catheter is introduced inside the gallbladder. Okay, a catheter is introduced inside the gallbladder, and gastrografin dye is diluted at the ratio of 1:1. And slowly we inject the dye inside the gallbladder. And after injecting the dye inside the gallbladder, we do a live fluoroscopy. And while doing a live fluoroscopy, we can see the dye is going into the duodenum or not, or proximally the dye is going into the biliary tree or not. This is a normal cholangiogram. In cases of biliary atresia, here we can see this is the gallbladder, this is the angiocath which is introduced inside the gallbladder in intraoperative cholangiogram. And here we can see this is the duodenum. The dye is seen in the duodenum, but we cannot see the biliary tree in the proximal side. So therefore, generally cholangiogram is repeated immediately, and if we still do not see the proximal biliary tree, there might be a biliary atresia more proximally. And I have already told biliary atresia is more common at the level of division of the right and left hepatic duct, which is also known as porta. So the surgical controversies are laparoscopic Kasai procedure are still limited, not much done still today. If there is failure in Kasai procedure, or even after Kasai procedure the child still develops jaundice, then we have to do and we have to think for liver transplantation. And use of steroid is still controversial. If some surgeons still use steroids, and steroid is used at that is prednisolone, that is 2 mg per kg per day for 6 weeks, and this is slowly tapered and then stopped. Post-operatively, we have to give ursodiol, that is 10 to 15 mg per kg per dose twice daily, and also we have to give the vitamin A, D, E and K, that is given 1 ml per day to the neonate. Outcome is potential candidate for liver transplantation should be the liver transplant. If Kasai procedure fails, then we have to do liver transplantation. So liver transplantation either from the living donor, and most common cause of liver transplantation in children is biliary atresia, I have already told. And generally in living donor means generally parents are a good match for the neonate, and parents generally give the liver to the neonate. So this is the living donor, or a cadaveric donor, that is from a the person who have died because of cardiac arrest or because of head injury. The person is brain dead, then that is known as cadaveric donor. So either we can take the liver from a living donor or cadaveric donor for liver transplantation. And this outcome of biliary atresia depends on the age of presentation, operative technique, which operative technique we have done, severity of liver disease and comorbidity that is associated with the biliary atresia. Better outcome is seen. We can see a better outcome at or before 90 days. And patent, if there is a patent gallbladder, the neonate also have a better outcome. Now, what are the complications of the biliary atresia? The complications are: number 1, nutritional; number 2, cholangitis may be present in 33 to 60% of cases, and this cholangitis is due to portal venous infection. There is presence of cholangitis, or there may be portal hypertension in 34 to 76% of cases. And because of portal hypertension, there may be ascites in 60%, there might be esophageal varices because of portal hypertension, and there might be hypersplenism. What is hypersplenism? Hypersplenism is present in 16 to 35% of cases, and hypersplenism is increase in activity of spleen, that is known as hypersplenism, increase in function of spleen. So thank you for watching, guys. Please do like, share and subscribe to my channel so that I can make more free videos for all the medical students out there. Thank you, guys.